I was with you, Terry.
That's right.
Any face
That's
for
right.
Face for blue wall.
And, you know, that's a good thing. Sometimes patients, they don't get it. So you could just say, maybe I should have said that. You turn and face that wall. Okay? And so that's what we're going to, and I'm going to have you turn and face the one more quarter turn. Thank you. And then one more to the right. There you go. And then back towards me. Thank you, Ben. Would you turn and walk away from me about 6, 7 steps, please? Right? And then you're going to have the patients. That's great. Thank you. Turn around and come back. So here's what we're looking for. And you guys are going to tell me this. You don't say this to the patient, but you'll be telling the examiner, whether it's Dr. Brewster or myself. You're going to be looking for the 6 S's, right? Remember me telling you? You're going to be looking for size, shape, symmetry, swelling, scarring, subluxation, all of these different things. Now, if I was really doing this examination on this patient, you want to see as much of the patient as you can. So definitely you'd want to have at least examination shorts on them in case you're seeing anything down below at the knees or the ankles, whatever that may be affecting them. You want to have a gown on, or sometimes what they'll do is they'll use something up top so that you can see the spine. Because when you're looking at the patient and they're moving, you could look for what? Hip changes, you could look for gluteal changes, you can look for evidences of genuvalgum because of coxivara, coxivalga. You can look for toe pointing, you can look for scoliosis. All these different things you're going to be looking for when you're examining your patient, okay? So you're just going to keep that in mind. And as we go through other parts, you'll say, oh yeah, we've got to look at that and this. Okay, so that's what we've done. We've done our physical examination, our visual examination. The next thing we're going to do in this is we want to see, is there any evidence of any atrophy, maybe in the thigh muscles, the quads, etc. So we're going to do we're going to measure the circumference of the widest part of the thigh. And so the way you're going to do that, on here you're either going to have the metric system or you're going to have the standard system. I don't care which one you do, but make sure you do the same one from side to side, right? And when you do it, I want you to remember what you've done. So you could even say the number while you're doing it, okay? So I'm going to have you move forward just a little bit for me, thank you. And you're going to do it from the side for obvious reasons. We're going to go just like this. We're going to go down below. And then when we come up, we'll be here. And when we measure, you want to be what? How do we want to measure, folks? You want to measure the widest part parallel to the floor. This would not be acceptable. Has everybody got that? So you'll do this at this level. You're going to make your measurement. And I'm going to have you, could you turn and face the wall behind you? Thank you very much. Then we'll do the same process again. Find the widest part. Do your best to do that. And then come up and make your measurement. Does everybody have that? Okay. Very good. Okay. The next part of our examination is going to be lying on your back. Okay, so I'm going to have you put that down here. Now here, before the patient lies down, I'm going to be making sure, now in the test, she's going to have her own headrest paper, right? She's going to have her own napkin or whatever, but you as the doctor needs to make sure she uses it, because if you don't, I'm taking off a point. If you don't introduce yourself to the patient correctly, I'm going to take off a point. And not only meant in the examination, but in your dealing with the patient, you treat them with respect, courtesy, and so on. Has everybody got that? Okay, so I'm going to have you lay on your back here for a minute, please. Okay, so then we're going to go for our supine examination. The first thing we want to do with our supine examination is the temperature and dermatome. I always say the best thing to do in a football game is make a touchdown right off the bat. So anyway, so in your supine and prone examination, TD, we're going to do temperature and dermatome. Okay, everybody got that? That helps you to remember the order. That's great. So, temperature, we definitely want to check over the bursa, and you always want to use the back of your hand because that's where your skin is the thinnest and you get a better feel for it. So it's just kind of quick and simple. Okay, it's about all you need to do. With dermatomes, you're going to take out your trusty reflex hammer and you're going to say, hi, I'm going to run this over your skin and it's going to feel like this, okay? And I'm going to do the comparison side to side. And I'll be asking you questions as we go. So I'm going to have you close your eyes when we do this. You always want to have your patient close their eyes. Now when we're doing the dermatomes here, we're just going to start at 12, and that's going to be about the iliac crest. So we're going to do, does this feel like this? Does this feel like this? And then of course we're going to come this way. Okay? So I'm going to come here. Does this feel like this? Mm-hmm. And does this feel like this? Mm-hmm. And does this feel like this? Okay? Now, along with the dermatomes, we also want to check the peripheral sensory nerves, right? Hopefully you guys remember. Peripheral sensory nerve coming down this way. The first one is what? Does this feel like this? And that is what? The anterior femoral cutaneous. Very good. Over here, does this feel like this? What is that? Very good. And does this feel like this? Which one is that? Obturator? Okay, very good. So we've done our temperature and our dermatome. So in conjunction with the dermatome, we're checking for sensory, because as you know, sensory does not always follow the dermatome, so we want to figure that out. So yes, you need to remember all that little bit of information that we've done in Ortho and R2. I know I warned you back then, but you need to know it just because you need to know. Okay? Okay, next thing we're going to do is is it bony palpation? Okay, so we're going to do our iliac crest, our ASIS, our AIIS. We're going to come across to the pubic bone. We're going to come over here to the greater trochanters, and then you can just come down the femur. Okay, has everybody got that? Okay?
Yeah.
All right.
My muscle is tender right there. I don't know why.
Well, yeah, and that's, you find all kinds of things, and you can always say to your patient, if anything hurts or causes you discomfort while I'm doing this, please inform me of that. Yeah, that's okay. Okay, the next thing we're going to do is our soft tissue. In our soft tissue, we want to look for things like lymph nodes. We want to look for like bursa. We want to look for ligaments. We want to look at muscles and things like that. Okay, so we'll do the inguinal lymph nodes, and you're going to do hand on hand, and you do not reach across when you do this. You only examine the side that you're doing. So you're going to come down like this, just moving around just in this direction here, and you're going to move to the other side. Any type of issues with the lymph nodes, right? Has everybody got that? You're going to compress over the bursa here. Which bursa is this, and which bursa is this? Anybody remember? Iliopectineal and trochanteric. Okay, so then you're going to bursa. One of the chief tendons that you're going to look at here comes from the ASIS down to the pubic bone, and that's what? No. The inguinal ligament.
Oh,
the inguinal ligament. Okay, and that gets involved with what? Anybody remember? Neuralgia paresthetica. That's where you can get entrapment. And one of the treatments for that is just some cross-friction massage over top of that ligament. Next, you want to do the muscles, the chief muscles we want to do. Remember, we were talking about them because people problems with the psoas muscle gets real tight. So you'll just come down here, and you'll palpate right down through here. And of course, palpate on the other side. And I also think it's a good idea to go back to the ASIS and what attaches there, sartorius, and then the AIIS. So the sartorius will come down this way, your rectus femoris this way. I don't care how far you follow the muscle necessarily, but I want you to definitely look at the origins of those muscles. Okay, sometimes it can be very Okay, has everybody got that? But if the patient says to me, hey, this is tender like she did, I'd probably follow that muscle further, right? And just try to isolate and see what's going on. All right, so after we've done that examination, we're going to do our ranges of motion, our active, passive, and resisted ranges of motion. Now, when your patient's doing these, you want to make sure that they're doing them and not, and that they're stable on the table so that you're getting a good motion on this. I'm not interested in numbers on this. To be honest with you, I don't know the numbers. I've looked at them 500 times, but what I am looking for is what? Right, I want to make sure that the patient is kind of even on from side to side. So the first thing we're going to have our patient do is I'm going to have you, if you would flex your hip, thigh all the way up to your chest if you can. There, no, no helping. Just like that. Very good, thank you. And you can put it back down. And can you bring the other one up? Very good, and take it back down. Did anybody notice a difference on that? This one came up further, probably because she stressed it with her hand. But you want to make a note, if this patient was in exam shorts, she probably would have had a better range of motion. Jeans, tighter pants on, That's not really what you want to do, okay? Okay, so next what I'm gonna have you do, if you would please, would you bring your knee up to about here? There you go. And now I'm gonna have you, can you turn your foot all the way that direction? No, I'm sorry. I'm gonna have you do this as far as you can. Very good, thank you very much. And see, I'm not inhibiting her, I'm just guiding her. Can you turn your foot out the other way? Very good, thank you very much, and you can put that back down. Can you bring the other one up, please? And again, take this one this way, very good. And then the other direction. Thank you very much. So that's our what, ranges of motion? Internal and external. When the patient's foot is going laterally, that's internal, because we're looking at the hip. We're not so much looking at foot, we're trying to understand what's going on at the hip joint, okay? Then the next thing I'm gonna have her do, I'm gonna stabilize here. Can you take this leg and move it as far out to the side as you can for me, please? Very good. And then can you take it as far over the other direction as you, no, I'm sorry. The same one, all the way over. There you go, thank you. Now, see, this isn't very good here. Did you see what happened? So, what do I need to do as the doctor? I need to change my stabilization. Okay, can you try that again for us, please? Very good, right? And then I'm gonna move around to the other side. And I'm gonna say, can you take this one all the way off for me, please? Very good, thank you. And then can you take it all the way over to the other side? Very good, thank you. And you stand at the head of the table when you're doing these for obvious reasons, okay? After we've done the active, we're gonna do what? Passive. Now, when you guys are doing the passive, I don't want you to just go like this, okay, because passive is supposed to be what? But relative to active, it's supposed to be what? A greater range of motion, right? So you're gonna do your ranges of motion like this. Okay, make sure you get a full range of motion on that. We're gonna bring the patient's leg up like this. I'm going to turn this all the way up this way. I'm gonna turn this all the way this way, right? And you're making notes of this as you're going through. If you want to do more than one at a time, that's fine. Don't do the whole examination, because I doubt if you'll remember it. So, this one here, I'm gonna come here. Now, if I wanted to go and do internal rotation on the other side, I can, but I think it's okay to do both internal and external rotation at this point. Has everybody got that? Now, remember, you wanna keep it up here at 90 when you're doing it. Then you're gonna do this, okay? We're gonna come here, okay? And I'm going to do this, okay? Stabilize this, please, thank you very much. Concentrating on that hip joint, and we're gonna, okay? Everybody understand that? That's our what? That's our passive. Can you raise your, I'm gonna hold resist here. Would you raise this off the table for me? Good, thank you very much. In here. Very good, thank you. And can you bring your leg back up for me, please? Okay, now can you turn your ankle, push it against my hand? Very good, thank you. Can you try the other one? Good, thank you very much. And bring the other one, oh, I'm sorry. Push up. Okay, bring this back up. I may have done that twice. Push in, okay, and push out. Very good. And I'm gonna have you just push your ankle out toward, your whole leg out towards me. There you go, and in. Very good, and in with this one. Good, and out with that one. Okay, so you've done your active, passive, resistant ranges of motion. That's all, a lot of it is neurological, orthopedic. You know, you're looking for range of motion, you're looking for strength, et cetera, et cetera. That's why it's important that you try to remember, like maybe what nerve roots might be involved, maybe what nerves, of course, could be involved, what muscles are involved, and so on. So it's all part of your examination. If you forget, go look it up, make a note. Person is unable to abduct or adduct or internally rotate, et cetera.
You gonna ask questions during the test?
I'll just probably make sure you're doing it correctly. I will ask questions on your written test. Okay, there are two 25-point written tests, one midterm and one final. Let me think of any type of questions I might ask you. I'll think about that, and I just pretty much want to make sure you know what you're doing. I don't know, I'll think about that, because I don't want to spring that on you and say, oh, I don't want to guarantee I'm not going to ask you any questions, but just have an understanding of what you're doing, not just the motions, right? What we're trying to achieve here. Right? So, but I won't beat you to death with that. I know I won't do that. Okay, the next thing we're gonna do, we're gonna do our measured and apparent leg length. The apparent leg length is the one that comes from the umbilicus down to the medial malleolus. Okay, so can you show me right where your navel is, please? Very good. I'm gonna just set this right in here. And again, whichever side you want to use is fine. What is it? 5 to 15 millimeters, I think, is normal, considered an acceptable range, or up to 3/5 of an inch, I think.
Can you see up
Yep.
here already?
That's correct.
Apparent, yeah, but for either one of these leg lengths, okay, but the first one is apparent, and the way I remember, can you show me your, let me get that. So, the way I remember that is, this looks like an A, right? So that's our apparent, right? Our true comes from where?
Is this millimeters or centimeters?
And you can do it in millimeters, you can do, if you're doing it in millimeters, then you should have,
5 to 15 millimeters is.
5 to 15 millimeters difference is considered
That's where
an
it's from.
acceptable.
Oh, different.
So it's really
Okay.
from ASIS to medium.
Yes. Okay, that's your true leg length, apparent and true
5 to
leg.
15.
The last thing we're gonna do is we're gonna do a deep tendon reflex of our hamstrings. You've heard about that, I don't know if you've ever done it, just, the way to do that is just to have the patient relax their leg against you here, just like this. Come up, for those of you in the cheap seats, if you wanna move your. I'm gonna grab onto the semimembranosus, semitendinosus tendon here, and I'm gonna look for any type of reflex that takes place within the spine.
She doesn't even get one.
Okay, so everybody got that? So that's your full examination in the supine position. Okay, then we're gonna have our patient, would you lay prone for us, please?
You would do both sides, right?
Yes. I probably won't have you do both sides on the test. Probably will not have you do both sides on the test. In fact, like when we get down into the ankle and so on, sometimes, like when you're doing all the different ligaments and muscles and showing you the tendons and everything, how they function, for time purposes, I usually just have you do one. Sometimes I'll have you do two, but of course, everything we're doing up here is, pretty much right there, so. In this prone, the first thing we're gonna do is make a touchdown, right? It's temperature and dermatome, right? And peripheral sensory nerves, so remember that. So our temperature, you're just gonna come down. And there's a bursa here, and that's your glute maximus bursa. That's right over the inferior lateral edge of our ischial tubes. Now, remember when we did the dermatomes come down here, we came down 12, 1, and 2? Has everybody got that? Or 12, 1, and 2. Basically what we're gonna do, we're gonna start up with 3 on this side. We'll just make it easier. I could have done it differently, but I was trying to just make it so you can remember. So 12, 1, and 2, then we're gonna do 3. Does this feel like this? And I've already informed her, so that's why I'm not doing it again. And she says, yes. And does this feel like this? Okay, and then 5 is gonna come down here. It all comes down a little lower, like a little rainbow. And then S1 comes down on the lateral side, as you guys know. And S2 is a little more medial. Does that feel like that? Okay? And the only peripheral sensory nerve we're gonna do here is does this feel like this? Is our posterior femoral cutaneous. Okay. After we've done our what's our next thing we wanna do? Our bony palpation. Now, you know all these bones, you've been palpating them probably since quarter 1. Again, you're gonna go to the iliac crest, but then you're gonna come down, what are these? PSISs. You're gonna get the what? Sacral tubercles. I'm gonna touch the bones you sit on, here and here, and I'm gonna come out here again, get the greater trochanter, and I'm gonna come down. So everybody got that? Okay, our soft tissue in this examination is, we're gonna be doing more just like ligamentous and muscular. So ligamentous, the chief ligaments here, what do we have? The sacroiliac ligament, the sacrospinous, sacrotuberous ligament, right? We want to make sure that we pick up our piriformis muscle that gets involved with a lot of people. And one more. What was that?
Ischium.
ischium, well, we've already palpated the ischium, but what was the other, I think there was another soft tissue.
Bursa, the
Oh, the
bursa,
hamstrings, okay, just, you can just come down.
and
here
the
and
glute
get
max
the
side.
Oh, yes, and then they get glute max bursa, thank you very much, and then come out here and get the greater trochanteric bursa again as well, okay? If you've done the greater trochanteric bursa in your examination, you wouldn't have to do it again, but on the test, maybe we've already done the prone. So I want you to make sure that you picked it up. Thank you very much for reminding me of this, okay? All right?
So on the test, will we be doing prone or supine?
Well, you're gonna get 5 points off of here, and I think I already showed you guys the test. It's on there anyway, it shows you how each one is worth so many points, and I'm gonna pick 5 points. I might give you one thing supine, one thing prone, one thing visual, it'll work along that line, okay? So if I give you prone soft tissue, then pick up the bursa if you've not already done it supine, and you're not gonna get both, I guarantee you, so. There's something else I wanted to say. Can't think what it is, it'll come to me actually. Okay, next one we wanna do is what? Active, passive, and resisted range of motion. The only motion we're really gonna do here is our hip extension, okay? Now, the problem with doing hip extension is we're looking for hip extension. We're not looking for SI extension, so keep that in mind. If you are interested in SI extension in your examination, I'm not sure what you're going to be looking for, then you might want to stabilize up here like you've done. But if we're looking strictly for the acetabular, we have to stabilize on the ischium and hold it down. Has everybody got that? So again, I'm going to touch the bones you sit on. I'm going to come here. I'm going to hold this down. And I'm going to ask you, can you raise this leg off the table as high as you can?
Nope.
There you go. Good. Right? So now you can see we're getting strictly the motion there. Okay? So, again, try this one. Good. Very good. Then what I'm going to do is I'm going to do the what? Passive. And I'm going to say, okay, can you push up against me, please? Thank you very much. And again, thank you very much. Okay, active, passive, resisted range of motion. All right, and I think that's all for the prone. And the next part of our exam is going to be orthopedic tests. So you could get any orthopedic test. This would be a good time to review some of the orthopedic tests. Anybody have any orthopedic tests they'd like to review for the hip?
Can you do the logo?
Can you stay as that patient?
Yeah.
I'm gonna have you lay supine. We'll do a bunch for hip lesion. One of them is the log roll test. And what the idea of the log roll test, you're gonna have a hand just proximal to the malleoli, just proximal to the knee, and you're just gonna roll this back and forth. And one of the reasons for this test is it helps to really isolate that hip joint. When we do this, you got a lot of other structures coming into play. So we're just really trying to isolate that. Okay. And again, hip lesion, bunches of hip lesions, ligamentous tear, tear. You can have osteoarthritis. You can have a labrum tear. You know, there's just so many things you can have. Impingement mechanisms, all kinds of things that go on with that. So that's a log roll. Of course, this one is what? Does this cause you any pain? Does this cause you any pain? Cause you any pain? Does this cause you any pain? Does this cause you any pain? Right? And remember, you always start on the good side first, right? And in fact, we probably should have done the good side first as well as our range of motions and things like that. Remember, in all your examinations, if you can do a bilateral examination and do the good side first to get your baseline, you're always better off.
And on the test, we just do one side, right?
Not for your range of motions, and not for this one either. No, you have to do both. But if you're just looking for a muscle in the lower part, I'll probably say that's all right. Just show me the muscle in this ankle on the one side. You can do it one side, you can probably do the other. Ligares, right? Can come like this. Everybody remember these? Okay. Fidere, we're going to come this way. We're going to adduct, and we're going to internally rotate, right? That's more for what? Acetabular impingement. This one is what? That's right, scouring, and that's primarily for what type of lesion? Labrum tear.
So as far as memorizing orthos, we're just gonna be doing the hip ones for this test?
Yes,
Okay.
yes,
I have a question.
yes, ma'am.
If you're doing scouring on your patient, Are you expecting them to have pain in all ranges of motion? Or can it
You're
only
trying
be
to actually
certain?
catch the labrum, so you might not have it in one range of motion, you might, at this point it really, I didn't like that.
Yeah,
You know, it all depends on what's going on in that, you know. That's why you really wanna get the whole range of motion to see if I'm catching that or if I'm not catching it, you know what I'm saying? It's not just like a simple.
gotcha.
Okay, some other tests for the hip you might want to do. Can you lay on your face down for us, please? Does everybody remember what this test is? We're gonna come like this, we're gonna go like this, I'm gonna palpate, I'm gonna drop this out till the greater trochanter is parallel to the floor. I'm gonna drop a line, I'm gonna measure it here to see if it's between 12 and 25 degrees. Does anybody remember that?
Yeah.
That's what? No, that's Craig's test for anteversion and retroversion. If it's greater than 25, it's anteverted. If it's less than 12, it's retroverted, right? And you would see that with anteverted, you'd see a toeing in. With retroverted, you'd see a toeing out. Okay? Can't think of any other test. That's terrible. Can anybody think of tests for the hip? Oh, we could do like a Trendelenburg test. Would you stand up for us, please? With Trendelenburg test, as far as examining your patient, you'd probably see a Trendelenburg gait. You would have seen that in your visual. Every time they picked up that side, opposite of the weak side, it would just drop down when they're walking. So you probably see that. So you can have the patient hold on to a wall or something to stabilize themselves, but not so much that they resist that. So then the side that is the weak side is the side they're posting up on. So if I think this is the weak side here, then they're gonna stand up on, no, this one first, right? There you go. And then do the bad one right there. You got a little bit backwards. Okay, has everybody got that?
So will you pick a condition for, or orthopedic?
Yes, I'll probably say to you, I might give you, you think your patient has a labrum tear. Or I might just say, your patient you suspect a hip lesion. Or I might say, something like,
And
might
then
be
we
a little
choose
more
an ortho
specific,
for what you do.
might be a little less specific,
Okay.
okay? As you guys remember, when we get to the knee, there's a lot of things that go on there. So you're really gonna have to know these orthopedic tests, okay? And then your final thing that you're gonna consider, and I'll ask you, I might say to you, okay, Megan, you're the doctor. Now you've done your whole examination on your patient. What would be your final considerations with this patient? Should you what? Do labs? Are labs important? Right? And do I wanna take x-rays? And they'll be that simple on the test. I might look at Tara and say, okay, Tara, you're examining Nick, and for your what's your final considerations with this patient? She would say, do I need labs? Do I need imaging of some type?
So we say both.
Yeah, you have to say them both for a point, so it's very easy to get that point. Not everybody's gonna get that question, but some of you will. Just remember that. We've done our whole exam. What else do we need to do? Do I suspect that, I feel in here and all of a sudden this person has a lot of swollen lymph glands? Is there a lab maybe that would be appropriate for this patient? I don't know. We're also gonna be looking at swollen lymph glands behind the knee, right, so. Okay, so that's our process, and we have about 12 minutes, and